Hello, my name is Dr. Daniel Bruns, and I am a pain psychologist. I teach physicians about the nature of pain, and I teach my patients how to cope with it. I want to talk about the strangest case of pain treatment ever. I also want to talk about what this case means for us today. Let me start out by saying that pain is really strange. Science has actually struggled for centuries to understand it. But pain poses a series of complex riddles, and over the centuries, we've often gotten the answers wrong. The problem here goes back to a mistake that was made in 1664. One of the reasons why pain is so misunderstood is that we think about it wrongly. We think about it in terms of something called the biomedical model, which was first proposed over 300 years ago. Now, this model has become deeply embedded in our culture and our way of thinking, and we don't realize that it's not based on science. It was based on a theory by Descartes, published in 1664. Descartes believed that mind and body were separate and distinct. And it followed from that if you think about pain, that pain is either real and biological and due to what's called pathophysiology. It means like tissue damage or something wrong physically with the body. Or pain is not real and in your head. Since mind and body are distinct, it comes from one of those two places. It's either real and in your body or not real and quote-unquote in your head. Unfortunately, this model contradicts science. If we apply the biomedical model to treatment, it has implications for two different types of treatment. First of all, if you have real pain, you can either cure it or remove the pathophysiology. So if you have pain from a broken bone, you either fix the fracture, or if it's from a tumor, you cut out the pathophysiology. Alternately, you ameliorate the symptoms of pain with some kind of medication, something that maybe calms the pathophysiology. Thinking about that way leads us into a number of dead ends. Let me explain. In order to understand the biomedical model and its weaknesses, I want to go back to the very early days of this model and explain a case to you, a strange case, that of Charles II, King of England. It helps to see how the whole model went wrong as they were focusing on trying to get pathophysiology out of the body and trying to soothe the patient without taking other things into consideration. Charles II lived from 1630 to 1685. He became the King of England and was one of the world's richest and most powerful men. He had the best of everything. In 1685, Charles II reported the onset of back pain along with a number of other somatic symptoms. He sought the help of his doctors. What follows is the treatment plan for Charles II. Note that this was happening 21 years after Descartes had published his theory of pain in 1664. And the treatment of Charles II generally followed Descartes' recommendations. Let's see what happened, and you can see what you think. A pint of blood was extracted from his right arm and a half pint from his left shoulder. This was followed by an emetic, 2 physics, and an enema comprising 15 substances. Next, his head was shaved and a blister raised. Now just note that part of the theory of the biomedical model is to remove pathophysiology, so they're trying to drain out blood, which may have an excess of humors, which is this old 17th century concept, followed by an emetic, which induces vomiting, physics, which is a laxative, and enema, so they're trying to clean him out. Next, his head was shaved and the blister was raised. And again, the blister is supposed to be drawing out poison. Following in rapid succession were more emetics, sneezing powder, bleedings, soothing potions, a plaster of pitch, and pigeon dung was smeared on his feet. Note that we have things added now to ameliorate symptoms, the soothing potions, the plaster of pitch, and apparently pigeon dung was supposed to be soothing? Okay. I guess I thought that back then. Potions contain 10 different substances, chiefly herbs, as well as 40 drops of extract of human skull, were all swallowed. Following this extensive treatment, the king died. What killed Charles II? He got the best care available at the time. He could afford anything. But his physicians lacked a basic scientific understanding of what was going on. In the final analysis, it may have been his treatment that killed him. When we think about the treatment that Charles II got, in retrospect, from our historical advantage, it seems ridiculous and dangerous. But how are we doing today? We tend to think that today we have so much more science available and our treatment is so much better. Let's examine how we're doing today. The biomedical model today is manifested in two primary ways. First of all, there's the desire to cure or remove pathophysiology. This is manifested through surgery and various sorts of interventional pain procedures. And secondly, through the amelioration of symptoms through pain medications, which have been largely opioids, but also a variety of others as well. So how well do surgeries work? Let's explore that. There was a study of 942 spinal surgery patients treated at an academic surgical center. And what they found was that spinal surgery was associated with a high risk of adverse events, with up to 87% of patients having one or more complications. This was 10.5% intraoperative, so during surgery, and 73.5% postoperative. Now, these risk factors ranged from moderate to serious, ranging from electrolyte imbalance post-surgically to excessive blood loss during surgery or infection. Also striking was that there was a 1.4% mortality rate with spinal surgery. This is from Street 2012. In another study of patients undergoing lumbar fusion, ultimately the vertebral fusion was successful 84% of the time, so the bones actually fused most of the time. But this did not make the patients happy. About half were dissatisfied with the outcome, and 38% were left totally disabled following the surgery. So even though they could get the vertebra to fuse, that didn't mean that the patients were satisfied or functional. So what if we compared spinal surgery outcome to the outcome of a different treatment? Psychological coping treatment for back pain. You couldn't think of two treatments more different. Spinal fusion versus teaching coping skills. And yet, remarkably, it was found that spinal surgery was no more effective than psych coping treatment for back pain. And there have been two studies demonstrating that. Where the two treatments differ, though, is in safety. As you saw, there is a 1.4% mortality rate with the surgery, and also the cost. And so if you look at just the initial cost of surgery, while they're in the hospital, not follow-up care, not medications, not physical therapy or follow-up imaging, just the cost of the surgery, that cost is 168 times more than the cost of psych-coping treatment based on analysis we did in 2012. So the surgery for back pain is no more effective, has more risks, and is far more costly. The other part of today's biomedical model is to ameliorate symptoms with pain medications. So how well do pain medications work? In the United States, doctors have prescribed a lot of pain medicine. If we look at the global opioid consumption in 2007, which is the latest date available, even though the USA accounted for only about 4.6 of the global population, the USA accounted for 81% of the global consumption of oxycodone and 99% of the global consumption of hydrocodone. Here is an alternate way to crunch those numbers. We could think about this on a per capita basis. And if we do it that way, United States versus the world, in the United States we take 88 times more oxycodone and over 2,000 times more hydrocodone. That's a lot. So how safe are opioid medications for pain? Let's look at the American mortality rates for accidental overdose of various substances. The blue line here is the accidental overdose from heroin. The green line is the accidental overdose from cocaine. And the red line is the accidental overdose for opioid analgesics. So you can see as of 2007, which was the study from the Centers for Disease Control, if you add up accidental deaths from heroin and cocaine, it was still less than opioid analgesics. Now these trend lines have continued to go up, although while we don't have the most current information available from the CDC, what data suggests is that opioid analgesics has continued to climb, and more recently so has heroin, as people transition from pain medications that are prescription to heroin. Here's some more interesting statistics. The blue line here represents death from motor vehicle accidents, and the red from drug poisoning. And if we follow the trends here, we can see that motor vehicle accidents have been decreasing over the years while drug poisoning has been increasing. And in 2008, drug poisoning passed motor vehicle accidents as cause of accidental death. And in the trend line here, the main factor contributing to drug poisoning deaths is prescription drug overdose, and in particular opioid pain medication overdose. What we know from research is that opioids are effective pain relievers. What we also know, though, is that there's no evidence that opioids work long-term to relieve pain. There is evidence that opioids taken long-term are associated with an increased risk of death, and also with an increased risk of dependency. So what does all this tell us about pain treatment today? Remarkably, we're still prone to making the same mistake that the doctors of Charles II made. We have this faulty understanding of pain that was based on something that Descartes proposed, but which isn't true. This biomedical model regards pain as something tangible or real, like something you could cut out of a person or drain out of them. But pain only has a loose relationship with tissue damage or pathophysiology. The truth is that pain is a remarkable and complex feeling. Neurologically, it is half sensation, like a sense of touch, and half emotion, like depression. So there's a close relationship neurologically between physical pain and emotional pain. If you think about it that way, if somebody is unhappy, you can't use surgery to cut the unhappiness out. And similarly, you can't use surgery to cut out pain. You can put a screw through a fracture and screw a bone back together, or you can cut out an appendix, but you can't cut out a feeling. And that's the mistake. Also, as with Charles II, we still try to suppress pain with dangerous medications. But as we see in the opioid crisis, this is a recipe for disaster. Neither of these things work. Now, I'm not saying we never use surgery or never use opioids, but our misunderstanding of pain has led us to greatly overuse both of these things. So how then are we to think of pain? Over the last few decades, science has consistently shown that the biomedical model is not true and doesn't represent the actual nature of pain. What does have scientific support is something more complex, called the Biopsychosocial Model, where it's seen that pain has biological, psychological, and social components, that all three of those things contribute to chronic pain. The biopsychosocial model has been tested scientifically in numerous studies. A recent massive review looked at all the treatments for chronic pain, looking at treatments that help people feel better, function better, be satisfied with care, and compared surgeries, injections, medications, physical therapies, and psychological treatments for pain. Now, this review looked at the evidence for all these treatments, looking for which treatments have evidence that they work, that they are low risk, that they are low burden. I mean, some treatments work but have side effects and create a burden to the patient, and of two treatments that are otherwise equal, which costs less. And if you review all treatments for pain using those criteria, the winner, surprisingly, is something called cognitive behavioral therapy. It's a psychological coping strategy. Now, this makes no sense from the biomedical model, but it makes perfect sense from the biopsychosocial model, which regards pain as a feeling, part sensation, part emotion. With the biopsychosocial model, science has solved many of the riddles of pain. However, many more remain. But that's a topic for another day. If you're interested in understanding what science tells us about pain, watch the Riddles of Pain series at the healthpsych.com YouTube channel.